Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And my video today is mostly focused on physicians who do these exams, and it's how to tell if a patient's problems are functional or physical. As usual, everything I say reflects my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. Now, it's fairly easy to become cynical and jaded doing these exams. I spent a day doing Social Security exams last week, and I saw two patients of a sort I see regularly. These were younger men complaining of widespread musculoskeletal pain and inability to do much activity. However, they were obviously physically fit and worked out. In my medical career, I've treated bodybuilders and powerlifters, and I've been a ringside doctor for fighting sports for 12 years. I've probably done close to 1,000 pre-fight physical exams on trained fighters, both amateur and professional. And believe me, I can tell if somebody works out usually at a glance, just like I can tell if somebody smokes cigarettes, usually at a glance. So both of those younger men were trying to get me to believe a load of nonsense, and I was probably feeling kind of cynical. Then I got a patient with musculoskeletal complaints related to the low back, and the history really didn't seem to make much sense. They'd had a back operation, they'd been diagnosed with nerve root compression, but they continued to have problems after the surgery. The surgery hadn't helped much. So after taking the history, I did the physical exam, and everything was looking pretty normal until I checked the deep tendon reflexes in the legs. And there was a significant difference. The reflexes on the left side, the patellar and Achilles reflexes, were 4+, and on the right side were 2+. And there was definite non-sustained clonus at the left ankle. I thought this was odd, so I had the patient remove their shoes and socks and checked for Babinski's sign. It was negative on the right. The toes were definitely down going. However, there was a very subtle Babinski sign on the left. All of the toes except the third remained motionless when I stroked the sole of the foot. The third toe extended. I tried it 3 times, and there was no doubt the patient had hyperreflexia, clonus, and a positive Babinski sign in the left leg. The neurological exam of the arms was normal. Then I started thinking the patient had also mentioned in passing that they had neck pain. Doctors like to come up with one diagnosis for a patient's symptoms, but that isn't always the case. Occasionally a patient has 2 problems causing their issues, or even 3. And I believe that in this case, the patient had what's called double crush syndrome. They'd had nerve compression in the low back, which had probably been treated fairly well by the back surgery, but I think they were also having cervical myelopathy, explaining the signs of spasticity and upper motor neuron lesion in the left leg. If it hadn't been for those positive neurological findings, I might very well have dismissed this patient as functional. But the important thing is those signs cannot be feigned. They are proof positive that a patient has an organic problem. And I'd like to go over some similar signs that cannot be exaggerated or feigned. So I'm going to go in order of the way I do my normal physical exam and point out signs that only point to organic disease. If the patient has these signs, they're pathognomonic of physical disease. First, the eyes. Number 1, strabismus. Number 2, pupillary abnormalities, anisocoria, irregular pupil, or abnormal pupillary reactions. I should point out here that I once saw a patient who was trying to convince me that they had a serious illness, and they had a unilateral fixed and dilated pupil, which turned out to be due to their instilling mydriatic drops in that eye. In the neck, I look for lymphadenopathy, thyromegaly. I palpate the carotid pulses, and if this history suggests it, I auscultate for carotid bruits. None of these can be feigned. In the chest, I look for an increased anteroposterior diameter of the chest, use of accessory muscles, abnormal breath sounds which can't be faked, cyanosis, and clubbing. Now, here again, I've seen several patients with pretty convincing feigned airway and pulmonary disease. I've had a patient who feigned wheezing. However, they only had audible wheezing. There was no wheezing when I auscultated their chest. I once had a patient who was severely addicted to prescription medication and feigned stridor and upper airway obstruction to such an extent that they got themselves admitted to the intensive care unit and intubated so that they could get intravenous morphine for sedation. It took their attending doctor a week to figure out that they were a drug addict and not someone with a physical disease. In those situations, pulmonary function tests, which Social Security can order and will pay for, can be very helpful. In the cardiovascular system, tachycardia can be feigned or simulated, usually by ingesting stimulant drugs such as amphetamines or a lot of caffeine. However, abnormal heart sounds and murmurs cannot, and neither can jugular venous distension or peripheral edema. When it comes to the ears and throat, any findings in the external auditory canal or tympanic membrane are organic, as are intraoral lesions. In the abdomen, jaundice can't be feigned either, although keep in mind Gilbert's syndrome. A long time ago, I worked with a nurse who had Gilbert's syndrome, and although she was perfectly healthy, from time to time her sclera would turn bright yellow. Enlarged organs, ascites, masses, and hernias are all pathognomonic of physical problems. Now, the most common sort of complaint one sees in Social Security disability cases is musculoskeletal problems. And the most common musculoskeletal problems are problems related to the neck and low back. So it's important to know the musculoskeletal and neurological signs that point to organic disease. It's very difficult to tell if joint tenderness is real or not. However, it's impossible to simulate joint swelling, whether that's due to bony hypertrophy, synovial hypertrophy, or joint effusion. Likewise, joint heat and redness cannot be feigned and are proof positive of organic arthritis. Another sign that points to organic disease is joint crepitus with motion. When I have a patient who complains of knee pain, I always put a hand on the knee and flex and extend it and feel for crepitus. In the day that I mentioned last week, I had a patient who complained of shoulder pain and told me that their shoulder clicked sometimes when they moved it. I put my hand on their shoulder and asked them to try and make it click, and sure enough, I could feel a definite click or clunk. That cannot be a sign of functional disease. They had organic disease of the shoulder. Another physical finding is joint instability, such as in the knee, an anterior or posterior drawer sign. As I mentioned a few videos ago, I recently saw a patient whose left thumb subluxed. In terms of the neurological exam, weakness is one of the most commonly feigned signs, along with sensory loss. However, unilateral facial weakness always points to organic disease, as does, in my experience, unilateral sternocleidomastoid and/or trapezius weakness. Likewise, every time I've seen a patient with disorders of tongue movement, they've had organic disease. Now, although muscular weakness is often functional and not organic, muscle atrophy rarely is functional. You have to keep in mind, occasionally you'll encounter a patient who just stops using one limb. I had a clearly mentally disturbed patient once during Social Security exams who decided that there was no way they could move one arm, and the arm was withered. There was no physical reason I could find for not moving the arm. On the flip side, I had a friend who was a surfer and a weightlifter, was very muscular, and injured his neck surfing. And what happened was the pain radiated to his left arm, and over a month or so, his left triceps atrophied significantly. All the rest of the muscles in his left arm were normal. That's impossible to feign. That it clearly indicated that he had cervical nerve root compression, and when he had neck surgery, he regained his triceps muscle mass. Other muscle and motor signs that must be organic include fasciculations. No one can reproduce fasciculations voluntarily, tremor, and spasticity. In a similar vein, a positive Hoffman sign or Babinski sign always points to organic disease. In terms of dermatological issues, pallor indicates organic disease. Most rashes also indicate organic disease. However, there are two exceptions. The first is neurodermatitis, a skin disease caused by picking at one's skin. This produces erosions and scarring in the areas of skin that are easily accessible, and significantly, the back is spared. This is a psychiatric illness, and for reasons unknown to medical science, these patients are absolutely resistant to the idea that they are picking their own skin. I've also treated a patient with lichen simplex chronicus on the back of the neck. It's a form of neurodermatitis caused by continuous rubbing of the back of the neck when anxious. This produces an itchy raised plaque, and it's most commonly seen in Asian women. Finally, I'll touch briefly on signs of mental illness that cannot be feigned, although I really don't do psychological assessments myself. When it comes to schizophrenia, people often feign psychosis in hopes of being found not guilty by reason of insanity. However, they usually only display the positive symptoms of psychosis and don't display the negative symptoms, such as abulia or anhedonia. An interesting observation is that almost every psychiatric inpatient facility always has a few patients who are malingering, and probably the best way to pick them out is to ask other patients. The hospitalized mentally ill seem to be very good at sorting out who's really ill and who's pretending. Well, I hope this has been helpful, and as always, remember, if it happens, it's possible.